I was asked to project myself in the future and report the future of vascular neurosurgery on the 6th of June 2031, which is in a few years. So I'm driving to the hospital this morning on the Friday, 6th of June 2031, and I actually hear that we remember the 6th of June 1944, which was the D-Day.
The D-Day was actually the result of a global effort. There was a long-term shared vision in the part of the world to actually build a new world based on the principle of democracy, self-determination, and full prevention of future aggression. And there was a short-term aim just before the D-Day, which was actually to defeat the Axis power and to defeat totalitarianism. There was an alliance, a global alliance with many different countries. And I think that at that time, we are reminded now that there was a big effort of coordination. And there were the tools, the communication tool, to allow global coordination of intelligence, of resource exploitation, coordination of innovation, coordination of information dissemination, and long-term planning. And with all that information and all that coordination, the alliance was able to build up a strategy, and the idea was actually to defeat the Germans and start with coordinating a double front attack. So everything was about organizing that specific day, which was key in the war. And you see that there were multiple troops coming from multiple places. Everything was highly coordinated at the global level. And that makes me think today, well, that's what's going on now in health. So in health, we all have a long-term shared vision, which is to promote better health globally. We have everyday short-term aims, which is to treat our patient, so manage particular diseases in specific patient, doing personalized care, and also thinking about our resources. So we need to be optimizing. We have an alliance. We have health organization, academic societies, health networks, caregivers, scientists, patients, patient associations. And we have now tools. We have assessments. We have risk-benefit balance tools prior to the intervention. We are able to coordinate our innovation. We are able to coordinate the exploitation of our resources. We can optimize our intervention. And after each intervention, we are actually reporting our results. We are reporting if we're happy with our results, if the patient are doing fine, and we're following up people to actually integrate over their lifespan. So the strategy today is to treat this AVM, which is not a complex AVM, but it's in the Broca area on the left-handed patient, and this is on the right side. And so what we're going to start is create a digital twin, and then we're going to simulate the disease natural history, and we're going to simulate different managements. We're going to simulate the intervention itself. We're going to monitor the intervention and maybe do corrections during the intervention, and then assess and debrief the intervention. So the creation of a twin is actually just taking up images we have. So we have a CTA now today. A CTA, we have a ball top image, we have an angiography, we have a board MRI that confirms that actually language is on the left side. We did some tensor diffusion imaging to actually have the tractography, and we confirmed everything with transcranial magnetic stimulation just to be sure that everything was localized at the right place. And we actually rebuild everything in a 3D reference frame, and we visualize it using magic leaps or any kind of devices that allows to explore the angioarchitecture, explore the brain structure, and we can do that alone, we can do that as a team, so we can actually discuss and design the proper intervention strategy. We also assess what we locally have. So we have an operating room with a microscope. The microscope allows magnification. It can be an exoscope. We still have a microscope. We can actually visualize blood. We can visualize the flow. We can visualize also the metabolome. We can see what is the balance between the blood flow and the metabolic needs. We can map this, and we have a navigation that allows us to actually project in mixed reality in the microscope the 3D representation of the models we just looked previously, and we can actually readjust it automatically for brain shift. We have neuromonitoring, which actually allows to simulate awake surgery, and we have an angio suite, which allows to make a proper control at the end of the surgery before actually we close the head so we can apply corrections. Now, we simulate the disease, and actually we have a very preliminary model here where we have initial conditions, we have different ways to treat, and we have an outcome. And this, over time, with more data, is getting more and more accurate. And what we can see here is you have the usual factors of age, location, size of the AVM, the deep venous drainage, the compactness, and you see all the distribution you have in the population. Now we have a specific patient, so we just align now. This is a female, which is 42 years old. The AVM is a non-eloquent area. The size is 2 centimeters, and there is a deep venous drainage, and it's compact, and you see that most of those patients are actually currently treated by surgery, and that the results are fairly good because 90% are doing a great outcome and 10% are having a poor outcome. But now, what happens if we treat before or after bleeding? So now we can actually see, if we treat after bleeding, we see that obviously the outcomes are worse. There's 30% bad outcome, 70% good outcome, but you see that most of the cases are treated by surgery. And here, if it never bled, then you see the outcomes are much better. And you see that some patients are observed, but most patients are still operated. Now, when you look at people observed, you see that the outcome is actually not as good because there are 10% of bad outcomes because actually the AVM had bled. And when you look at surgery right away, you see that the outcome is much better. So because we actually explored all the different possibilities using that model, we actually decide to go for surgery. Now, here, we simulate the surgery. So we look first at the angiogram to have an understanding of the time dimension and see how this AVM is fed. And then we actually represent and first look at how we can better position the patient to be comfortable. We heard about the position of the neck, the shoulders, and the back of the surgeon. So we just organize so we can actually be very comfortable during the whole procedure by optimizing the positioning of the patient. We design the proper craniotomy. We don't like to have too small craniotomy for AVM. We want to be able to see around, not to have the veins on the edges, which are compressed. And here, actually, there's one unique feeder, so it makes it very easy to access the feeder. The feeder is in the Sylvian fissure. We should organize to have a proper projection on the Sylvian fissure to actually go to this feeder and clip the feeder right at the beginning of the operation. And then we can actually visualize without the nidus to see which are the distal connection to the nidus, so we can actually understand the 3D architecture before the surgery and know where we're going to have the bleeding points during the surgery. Now we do the intervention, and during the intervention we have our mixed reality. So here we have the angiogram, which is superimposed on the operating field. We can see that everything is very well adjusted. And then we can actually see the blood, and we can measure the blood flow. And we have here a quantification of the blood flow. And we look for the Sylvian fissure. We identify with mixed reality where the branch is. We open the cistern just right in front of the small vessel. We clip it, and then we do look at the flow again, and we see that actually the AVM is killed out. So we remove the AVM, and we do an angiogram during the operation, and we see that the AVM is out. But we see that there's something which is unexpected we didn't see before, is that in the lower part, behind the AVM, there is a pyelofistula. So we actually go and remove that pyelofistula too. And after this, we have a complete correction of the disease. The patient is waking up and doing fine. Now we do an intervention evaluation. And here is very important that we actually do a readable intervention report, which is integrated, synthetic, and structured using harmonized definitions and semantic using standard operating procedures, so we actually can feed a data bank, which is actually included in the security health information system that allows us to improve the model over time. So to add a new element, which is now the different tools we have during surgery, but it could be all the different tools in endovascular, and it can be any other dimension that we can add to the model. And we can progressively build up a model which improves our care. Thank you very much.